Hello, everyone, and welcome. Thank you for joining us for today's installment on Child and Family Focused CCBHC Learning Community. My name is Neerja. I am a director with the National Council and also a co-director of the CCBHCE National TTA Center alongside Samantha Holcomb, which I'm pretty sure most of you have already interacted with in previous installments. Next slide, please. So as a brief disclaimer to today's session, while the session is intended to provide information, the National Council team and presenters, today's presenters, are unable to answer any questions on behalf of SAMHSA. If you have any particular or specific questions as it relates to funding opportunity, please direct those questions to your SAMHSA project officer. Next slide, please. So as we all know, CCBHCs have requirements related to timely behavioral health screening, assessment, and diagnosis, along with comprehensive treatment planning, and also the requirement to use standardized and validated screening and assessment tools. So in today's session, what we hope to showcase are some examples from Minnesota on best practices when it comes to screening and assessment in youth, in our youth population, and concrete examples of screening and assessment processes and tools as well too for our young population. In terms of our speakers today, let's welcome our speakers today. First, Dr. Christopher Bellonci, who's a board certified psychiatrist. He's also a senior policy advisor with Judge Baker Children's Center. And then we have Cassie Subbert, I hope I said that right, Cassie Subbert, who is a licensed marriage and family therapist, and as well as a school-based professional with Alluma. And last but not least, Dr. Singh, who is a clinical behavioral health director at the Department of Human Services in the state of Minnesota. So with that, I will pass it on to Chris.
Thank you, Clement, and welcome everyone. These are the learning objectives for today's session. So we're going to be discussing screening and assessment of youth for behavioral health symptoms and conditions, talking about several specific screening tools and strategies to implement them. And then we'll be focusing on one CCBHC, on how they develop their screening and assessment procedures. We'll talk about the impact of COVID-19 on screening and assessment needs, and then also the importance of cultural responsiveness in screening and assessment processes, and then the role of state partners. So why do we screen for behavioral health conditions in youth? As many of you will know, mental illness impacts approximately 50% of adolescents in their lifetimes. And 50% of mental illnesses experienced by adults first began at age 14 and 3/4 by age 24. So the whole purpose of screening is really to identify as early as possible the needs of children and adolescents so we can get them services and supports in the hopes of mitigating their illnesses. We also know that adolescents from minoritized racial and ethnic groups are more vulnerable to mental health problems than their white counterparts. They're also less likely to use mental health services. And so by screening, we might be able to draw in some of those underserved racial and ethnic minoritized groups, as well as other youth who face mental health disparities, such as those from lower socioeconomic households, those who have experienced significant trauma, including children in the child welfare system, LGBTQ youth, and youth involved in juvenile justice systems. So even before COVID-19, mental health challenges were the leading cause of disability and poor life outcomes in young people. As many as 1 in 5 children between the ages of 3 and 17 in the US have a reported mental, emotional, developmental, or behavioral disorder. So this is not a small population. And we know that as recently as 2016, half of the 7.7 million children with treatable mental illness did not receive adequate treatment. And that comes from a new Surgeon General's advisory about protecting youth mental health, which I encourage all of you to take a look at. Screening ideally can result in early detection and treatment. That's really the goal of screening. Early intervention can help reduce the severity of an illness. It can even, in some cases, delay or prevent the onset of major mental illness. So if you're seeing symptoms before a full disorder is presented, you can sometimes prevent the onset of that disorder. We know from studies of adults that behavioral health conditions suggest, on average, individuals will go for as long as 10 years before receiving treatment for their behavioral health condition. Not surprisingly, this can lead to other problematic behaviors as the individual is suffering from the mental health condition and perhaps developing maladaptive coping strategies, such as substance use disorders, to manage those symptoms. Patients with first onset that occurred in children or adolescent age group have significantly longer delays than patients whose first onset occurred in adulthood. This is a slide emphasizing that point. The lowest curve with the little circles is the children who first presented with symptoms as early as ages 1 to 12. And what you see across the x-axis, that's the longitudinal axis, is how long it takes for that young person to get into treatment. So in the worst case, it can take as long as 30 years for someone to actually receive treatment. The highest curve are the individuals whose first onset of symptoms was over 30 years of age. And you can see that they end up usually receiving treatment much, much quicker. And again, the point of early detection is to get into early treatment in the hopes of mitigating the severity of that mental health condition. So briefly, what is screening? Screening is used for the early identification of individuals at risk for a specific condition or disorder. It can be done in a universal way. So universal screening is being done, for instance, in the state of Massachusetts using the Subbert model, screening, brief intervention, referral, and treatment for all middle schoolers and all high schoolers at one point in time. So typically that would be the 8th grade and the 10th grade, where counselors in the high school and the middle school are actually screening all students for indications of problematic substance use and using the Subbert model. So that's one example of a universal screening approach. Screening is generally brief and typically narrow in scope, and it may be instituted as or administered as part of a routine clinical visit, such as a pediatric well-child visit. We also use validated rating scales to monitor treatment progress or outcomes or change in symptoms over time. And that's a good clinical practice to utilize. The nice thing about screening is that it can be administered by non-clinicians, including your support staff, if you have those in a pediatric or CCBHC practice. They can be done by an electronic device, so individuals can actually complete them themselves, or parents can complete them for younger children. And then support staff can follow an established protocol for both scoring and with a pre-established cutoff score and queue that up for clinical attention based on the screening results. Screening is neither definitively diagnostic nor a definitive indication of a specific condition or disorder. For that, we need assessment. So that would be the next area where we would be then thinking about a more complete clinical picture via the assessment process. Assessments are comprehensive, focusing on the individual's functioning across multiple domains. They can also aid in diagnosis or treatment planning in a culturally competent manner, and can identify psychological problems and conditions, as well as their severity, and provide treatment recommendations. So screening can identify those that need some services and supports. Assessment then narrows down what it is that the intervention needs to address. And that can even target you or track you into specific evidence-based practices based on what the assessment's results are. It can integrate multiple psychological tests, clinical interviews, behavioral observations, clinical record reviews, as well as collateral information. And it can include screening measures that are used in conjunction with other information from the assessment. May use screening results to determine the choice of instruments for an assessment, as I was just saying. So how do you select a screening and assessment tool? And Cassie is going to go into some specific detail about her CCBHC chose their tools. But generally, you're looking for a tool that has reliability. So that's precision of the test scores. So it helps to ensure that the repeated administration of a test will yield the same result. It's typically called inter-rater reliability. And that's something like the Child and Adolescent Needs and Strength uses a reliability measure to ensure that it's being consistently, or the results are consistent across different raters. Validity is the extent to which the test scores adequately represent the test taker's standing on the psychological variable. So if you're testing for depression, how valid is the result? So how often is the positive result on a depression screening instrument or assessment tool verified by a clinical evaluation determining that the young person actually has depression? Classification accuracy. This is the adequacy of cutoff scores and used to indicate whether a test taker has or is at risk of having a specific condition. To demonstrate that individuals with depression will score at or above a designated cutoff score. So it determines in a way whether or not there's enough functional impairment to characterize the individual as having a clinical disorder. And fairness is looking at equally reliable and valid for various segments of the population. And I'll have a slide talking about making sure that the screening and assessment tools have been normed for the population that you're working with. Because similar to evidence-based practices, there have been concerns raised about some of our screening assessment tools not being appropriately utilized and normed for minoritized populations. You also want to consider what are the training needs and the specific skills for any screening or assessment instruments that you employ. You want to use ones that are relatively easy to train your staff in, particularly if you're going to have non-clinical staff using some of those screening instruments. And specific training and skills may be needed in the following areas, including knowledge of appropriate measures for the specific referral question, and then relevant information about the specific characteristics of the individual being assessed, such as race, gender, language, or disability. And then developing expertise in the test administration or scoring. And this is the slide that came from work being done by the Youth Mental Health Disparities group at NIMH. And it is reflecting that biases in measures, constructs, and sampling can be significant limitations to achieving informative results. So we need to make sure that we're not baking in our racial biases into the screening or assessment instruments we're using. And so it's important to make sure that they've been normed for minoritized populations. It's also important to include community perspectives and context when you're deciding which screening and assessment instruments to use. And populations for whom detection and screening are particularly challenging, including so-called crossover youth. These are victims of abuse who also engage in delinquent behavior, or youth that are involved in more than one system, such as child welfare and juvenile justice settings. In those instances, collaboration among investigators, families, and clinicians is critical to designing better screening tools and clinical implementation tools. And I want to just note that the U.S. Preventive Services Task Force recently came out with draft guidelines that are somewhat controversial. So this is an opportunity to give some input into those guidelines. They did find that there is moderate certainty that screening for anxiety in children and adolescents between the ages of 8 and 18 has a moderate net benefit, but not for children younger than 8 for anxiety. And then when they were looking at screening for major depression, they endorsed screening children ages 12 to 18, but not for children younger than age 12. And then probably the most controversial was that they found there was not current evidence to assess the balance of benefits and harms for screening for suicide risk in children and adolescents. You know, we've known that with the pandemic, we've seen significant increases in anxiety and depression, as well as eating disorders and suicidal ideation, with a significant number of young people presenting to the emergency department with suicidal threats. So the American Academy of Pediatrics, for instance, is continuing their recommendation that we screen universally for suicidal ideation. So it'll be interesting to see whether or not any feedback to the U.S. Preventive Services Task Force changes their final recommendation, or if they're sticking with that, what that means for our practice. There's not a lot of downside in my mind to continuing to screen. I think the risk is relatively low by asking questions about screening for suicide. There's no evidence that we're increasing suicidal thinking for those young people that we're screening. So it'll be interesting to see kind of where that lands, and I'll be interested in any feedback people have during the Q&A about that point. So that ends my discussion about kind of background information about screening and assessment. I'm going to now turn it over to Cassie to talk about her CCBHC's work at Alluma.
Hi, everybody. I'm Cassie Subbert. I am from Alluma in Minnesota. And I just want to talk a little bit about what we've done in our youth and family program at Alluma as far as implementing screeners in our CCBHC. So part of what we've done is we brought together a team which had providers, administrators, management to discuss what screeners we wanted to use across our CCBHC. So we really tried to include people from many different areas to give some feedback on what would work best and kind of who could help us get those screeners out. And then we looked at screeners that had been vetted and normed for the ages that we serve, specifically in the youth department. So ones that had been around for a while and tested and proved to be accurate. So the purpose of our screeners at Alluma is we really want them to guide client-centered care, also helping identify the level of care, which also includes any of our evidence-based practices that we have here at Alluma. I listed some out that we've got currently. And then really to help identify areas of focus for assessments. So we use those screeners as we're doing the comprehensive evaluations to really help us understand where the symptoms are showing up the most and how where we can focus any services we're going to be offering, and especially any of our evidence-based practices. And then we also use it to track progress throughout the use or the family's care. So whether we're not making very much progress and we need to maybe adjust what we're doing or make some changes in the treatment we're offering, or whether we're doing the right thing and we're making some progress towards graduating from services, which is ultimately what we want for these youth and family. And then also note of change of symptoms or needs. Sometimes they come in talking about one thing, and as we do the screeners, then we are noticing maybe some anxiety or maybe some depression showing up for them that maybe wasn't being reported right away. So we also use them ongoing to just kind of monitor any change in symptoms or needs. Next slide, Chris. So this slide is just a little bit of detail about some of the screeners that we're using with our youth at Alluma. So,
sorry about that. We seem to have lost Cassie, so just give us a minute to get her back on. I think Cassie's last slide also helped to highlight another purpose of the screening, which is to identify what your population's needs are, and then making sure that you have a range of specific interventions, ideally evidence-based interventions, to meet those identified needs through the screening. So it's kind of a way of scanning the environmental needs and then matching the needs identified with the specific services. And it may mean that you then bring in new services or clinicians trained in specific interventions to address the identified screening needs. Cassie's computer accidentally shut down, and she's going to be joining in momentarily.
And while Cassie is turning her computer on, I want to add that our CCBHCs in Minnesota, and Cassie will be talking more about it, really use all these tools that are mentioned on her slide to make any changes in the interventions. That means if after a course of treatment, if there are any changes in the dosage, in the modality, these screening tools are super helpful in making those decisions. We are in the process of getting all this data. Our clinicians, our clinical staff do put in information. Minnesota really wants to work on reducing the work of asking our clinical staff to be putting information in the system. So right now the state is working with a bunch of providers to make sure that anything we can do to make it easier for our providers so they can spend more time with the clients and less on data reporting, while understanding that this data is important. So those are like some of the stuff that we will be working on. And I think there are questions in the chat, Chris.
There is a question. So
just for screening tools for transition. Right.
Correct. So Christopher or Neerja, do you have a response? So suggestions for screening tools for transition age youth, ages 16 to 25.
Neerja, did you want to take that?
There are, again, depending on which population we are talking about, there are some tools, like especially Mazie, we use that a lot with our youth who are involved with the corrections. We use that a lot, and it's a quick tool that really generates lots of information regarding the kind of interventions needed. There might be some more, and I think on the last slide we have a bunch of resources. If you go on one of those specific site, you will get some help in. SAMHSA suggests lots of screening tools for youth, transition age youth, but I have seen like Mazie being one that is widely used. Chris, do you want to add anything?
No, I think that's right. I think Mazie is great for the juvenile justice involved population. There are some that are set up for primary care practices. I'm most familiar with the ones for children. And some of these are listed right now on the screen we have from Cassie, including the PHQA. If you already know that based on the history you've taken that a young person has, for instance, problems with anxiety, then you might do a specific screen for that condition. If you know that they've been exposed to trauma or are likely to have been based on the fact that, for instance, they're in the child welfare system, then you might do the PTSD screener. So some of it depends on the population that you're specifically screening and kind of if you've got already an index of suspicion that you're looking for. And as Cassie noted, I thought that was quite an important point, that sometimes the condition that the young person may be brought into treatment for initially doesn't end up being the condition after you've done a more thorough assessment, or even during treatment, sometimes a different problem emerges. And so the ability to move from one evidence-based practice to another is also something that's quite important. And that's where some of these modular approaches, like the modular approach to the treatment of children or MATCH, allows you to move kind of seamlessly through protocols to address depression or anxiety or behavioral health conditions like ADHD or externalizing behaviors or trauma. And so that's where I think you want to think strategically about knowing kind of what in the totality of the population's needs are, and then picking your screeners based on those populations, including a recognition of whether or not the specific screening or assessment instruments have been normed for minoritized populations. And then making sure that the suite of interventions that you've developed are going to be able to align with the population needs as you've identified them. Neerja, I'm wondering if we should go ahead and move to your section and then come back to Cassie if she's able to rejoin.
I'm back on.
She's back.
Oh,
she's back.
I'm sorry for that, everybody.
Okay.
My computer turned off suddenly. I don't even know what it was doing. So
Gremlins.
I apologize.
It was gremlins.
Right. So to talk about the screeners, sorry for that interruption. We are using the PHQA, the GAD-7, the Columbia Suicide Screener. We're also using that 4-question PTSD screener and a CAGE aid, and we're using those for 11 years old and up. And then we also use the Cassie and the STQ for youth 6 years and older. And so we also, for our younger population, so birth to Birth to 5, we have the XC, the CBCL, and the ASQ. So the Cassie and the XC really are screeners that we use to help recommend the level of care that we might need. So whether it's just therapy, maybe we want some in-home services with some therapy and skills. Really, that just helps us hone in on, do they have a higher level of care need, or is it a little bit lower? And that also helps us maybe recommend services that we can't provide either, if they have a very high level of care need. The SDQ and the CBCL really help guide areas of symptoms of concern. So those are the assessors that, or the assessments we're going to be using as we're doing like the comprehensive eval, again, to just hone in on maybe what a diagnosis could be, our care planning, and then again, any evidence-based practices that we can offer that would help. The ASQ, we use that in our youngest population to identify developmental concerns and then really make those appropriate service referrals to treat the whole child's needs. So whether that's maybe some speech, or maybe that's some physical therapy or occupational therapy, OT, we really just want to look at the whole child there and see anything that they may be needing for their development. And then the Cassie and the XE and the STQ, we do those at the time that they come in for a comprehensive evaluation at the assessment. And then we do it every 6 months to monitor their progress and to see where they're at. And the Cassie we do also if there's a big life event, so if a child's removed from the home, if there's maybe a sudden divorce in the family, really any big kind of changes in their life, we will do the Cassie again to reflect that and see where they score. And then maybe something a little unique to Alluma is we've come up with a complexity scale rating that we have for 11 years old, all the way through adulthood. And this really is to help guide that client-centered care, our care pathways, and then it really drives our care coordination services. So the higher the complexity score, usually the more people and more services that get involved and wrap around those youth or those families. And so then as that team grows, then we have care coordination services that will come in and will kind of help get us all together in that treatment planning, in that doing what we need to for them. So, and those, the complexity scale rating we use at the time of the assessment and then every 6 months at care planning. Next slide, please. So where we would like to grow, we are trying to work on developing a complexity scale rating assessment for our birth to age 10 group. So part of that process then is seeking out some brief, appropriate, and then norm screeners for that age group. And that's presented a bit of a challenge in developing that complexity scale rating because there doesn't seem to be as many screeners that are brief, normed, and consumer friendly. We know that they work best when they're brief and they're easy to fill out and understand and gather the information that we need. So that's been a challenge for us. So we're continuing to look and work on that and how we can develop that. And then we'd also like to get a family assessment in place with our family services. So that could help guide some of our evidence-based practices that are family oriented and then their care development plan as well. And we'd like to be able to show how the impact of care and progress has been made in our families as well as we've been able to do with individuals. So that's Alluma.
Thank you. There was one question that came up about assessment tools and for transition age youth. So I didn't know if you had any recommendations for that.
I think we probably use the PHQ-9 for sure. We still use the Columbia Suicide. As far as some other ones, I'm not as familiar with those, to be honest, because they're in our adult services, but I can certainly reach out with some ideas from our adult team.
Great. I was saying the PHQ-9 too.
Yeah.
Okay, thank you, Cassie. And turning it over to Neerja.
Thank you, Cassie. Thank you, Chris. I'm Neerja Singh. I'm the Clinical Behavioral Health Director for Community Supports Administration at Department of Human Services in Minnesota. So as Cassie and Chris talked about the importance of screening and different tools and processes, I just wanted to take a few minutes and remind ourselves of the reality of pandemic that we all are still facing, and it's not going away, that's for sure. So the need for screening and assessment can never be greater than what we have right now. We have stress and loneliness on the rise, which is leading to lots of mental health as well as substance use related issues. Self-harm, suicide is on the rise. And then what our country witnessed, the long-standing racial and ethnic inequities, the tons of racial violence and trauma that our communities experienced, economic fallout, and what is this doing to our already cracked system of mental health? Our providers were stretched, underpaid, and now they are taxed further. Vicarious trauma is on the rise, and there is increased fragmentation between behavioral health and physical health systems. So with that said, I don't want to kind of say that the situation is really hopeless, but I wanted us to realize how important screening and assessment for behavioral health issues is at this time. Next slide, please. So what is Medicaid going to do? Which is an insurance provider for more than 77 million individuals. And when I say Medicaid, this does not mean that commercial payers cannot learn from the lessons that Medicaid has learned during COVID. It is for everywhere in the country to make sure that our members are screened for social risk factors. We can no longer continue to talk about social determinants of health as something that is going to come in future. We need to kind of screen our members for social determinants of health right now. We have to incentivize plans that advance behavioral health screenings in primary care. As Chris talked about in his presentation, there are tools that our primary care providers can use to screen for behavioral health right when the patient comes for their primary care visit. And most important thing, we have to ensure that screening and referrals for services are bidirectional. And our patients, our members do not have to go from one door to another with one form and another to get services they need. If we are talking about true integration, if we are talking about true one system, one-stop shop, then we have to make sure that the systems are bidirectional and people do not have to run from one door to another to get services for different aspects of their well-being. So consultation between primary care and behavioral health providers is a must. And that's the question Minnesota has been asking. Now we have started to survey our members since we are in the process of re-enrolling. We have started to ask a question to our members who are enrolling regarding the type of collaboration they're seeing between their primary care providers and their behavioral health providers, and also the type of collaboration they are going to be seeing. Next slide, please. Here are certain more recommendations that came from a report that was created by 11 states that came together, and Minnesota was one of them, to create a report which was called Medicaid Forward. And again, there is a link in the reference slide that you guys can access that report. But here were some of the key points as it related to screenings and in this report. One is that simplify requirements for assessment and add flexibility in our state requirements for a child. Right now, a child has to have a diagnosis before accessing any behavioral health services. So on one side, we are talking about getting services quick and also not to label. On the other side, we have this requirement that our children need to have a diagnosis before they can access any of our services. So what this group has recommended is to add flexibility and make sure that services are provided as soon as those are needed, and our children and our patients are not waiting for assessments to be completed. And given the workforce shortage, we all know how hard it is to get assessments in a timely manner. Chris already talked about it, but checking for racial bias in our instruments. Every instrument we are using has to be accounted for possible racial bias. And then remove cumbersome prior authorization, service limitation requirements. Cover for full range of evidence-based and culturally responsive screenings for children and their caregivers. And as on the next slide, I'll talk about some of the steps Minnesota has taken. And then, as I mentioned, leverage data from providers, plans, and other state agencies. So we are in the direction of looking at how Minnesota is collecting data and how we are trying to make sure that it is not a burden on our providers to provide us with this data, and also that the state produces solid outcomes as well as process measures for our providers to see when they submit any data so they can make informed decisions in their programs. Next slide, please. Here are some of the things that Minnesota has done. We are in the process of implementing early intervention assessment to include screening, brief intervention, and treatment in our early care settings. It is already passed, everything is done. We just have to kind of work with our IT systems, which I hope everybody knows how long it takes. We have initiated an interagency screening task force that will identify all social emotional screening instruments for young children in Minnesota. We have our child and teen checkups that identifies mental health concerns in children's and teens' lives, and also screens for maternal depression. Our child welfare department is also working to integrate improved mental health screenings into practices for children and youth. I briefly mentioned our work with our partners in juvenile justice, where we are really screening our youth involved in juvenile corrections for possible mental health concerns and what can be done as interventions. Next slide, please. Here is like something I really want to take pride in for Minnesota. We are encouraging our providers and also creating avenues to support the use of cultural formulation interview. Because as we all know, that DSM, Diagnostic Statistical Manual, has this wonderful tool that will help clinicians to really understand the cultural connotations of mental health diagnosis. Excuse me. So we want to create a statewide training for our clinicians on this tool. The second thing Minnesota is doing is we are incorporating culturally and linguistically appropriate service standards in all our behavioral health and disability practices. We are just in the process of issuing a request for proposals for giving our providers grants to implement these standards in our practices. Next slide, please. That I think these are some references and resources that I would encourage people to get.
Yeah, thank you to our presenters. So here are some of the references and resources that has supported today's discussion. A lot of great information has been shared in it, and I hope that some of the screeners that were discussed can be adopted and implemented into your practices and your day-to-day screening opportunities. I also wanted to share that as most of you may be aware of, SAMHSA recently released 2 grant opportunities to expand upon the CCBHC model. The deadline for the application is May 17th. So this is an opportunity for those who are already a CCBHC to get some additional funding to expand upon their efforts in the work that you're currently doing. And those who are new to the model or who have not had the opportunity to receive a grant in the past or wants to implement the CCBHC model in your system, there's also an opportunity to do so through the SAMHSA CCBHC PDI grants. In terms of a center, we have some upcoming and reoccurring activities that we would like to welcome our audience here to. So we have our monthly webinar and office hours, and those are mainly centered on the CCBHC criteria series. The next one, these dates looks like they're a little outdated, but we haven't one on scope of services as it relates to integration between substance use and mental health, and that's taking place on May 24th. And an office hour will follow after. We do have a monthly learn and action series that we actually started today on how you can optimize your data, your clinical data to inform clinical decisions and to help drive, improve the clinical outcomes of your patient. We had one, it's a 3-part series. Session 1 started today, and the next 2 sessions will be taking place in June and July. We do also have a monthly peer cohort calls, and these are designed for peer-to-peer sharing of information and learning. We have 4 of those in different capacity and disciplines. So we have one strictly dedicated to CCBHCE executives. We have one for program directors, one for evaluators and CQI leaders and medical directors. So if you belong to any of these cohorts and you are looking to learn from other members across the country and learn from those who have been in this model, have been working in this model for a long time, or those who are newly starting, this would be a great cohort for you to join and to learn from your peers. And these take place on a monthly basis.
Thank you. So let's take down the slides. We do have some questions for the panel. Cassie, the first one is for you. With the screeners that you showed, you have a broad array of screeners.
Mhm.
With all of these additional screenings, how long or how much time is being taken for these initial assessments?
Yeah, so we are allotted for the screeners, for the kind of some intake review and doing the comp evals, we're allotted about an hour and a half total for all of that. So I would say the screeners probably take 15 to 20 minutes. Most of these are done by the youth or the parents, but the Cassie is a provider one. So that one we are doing on our own.
Great, thank you. This question is either for Neerja or Christopher, or Cassie, you may have a response as well. It came up during Neerja's presentation, and the question is there a recommended tool that screens for social determinants of health that you recommend?
I can start and I can have Cassie or Chris jump in. One tool that we are really looking closely right now is Core 5. There is like a lot of research done on it, and the thing that really fascinates us about Core 5 is that it has cultural responsiveness built into it. So that is one tool, Core 5. But also I would also encourage participants to look at culturally and linguistically appropriate standards, the national webpage, and they have a lot of helpful information. If you don't want to use a formal, full-fledged validated tool for social determinants of health, it would really help you identify some of the key areas that we can just build in our initial paperwork, the intake, to really identify some of the important aspects. It has very good questions on poverty, employment status, access to services, as basic as transportation. So I would encourage people to look at that, but Core 5 is something, if you are interested, I would encourage to look at it. Core 5, I said, I will put it right here.
Thank you, Neerja. Christopher, Cassie, do you have anything to add?
Our complexity scale rating is a lot of those social determinants of health. So we ask about employment, housing, many of those questions. So I think that's kind of what's been developed at Alluma.
Yeah, and while it's not exactly a social determinant of health instrument, I do think thinking about adverse childhood experiences is a way of getting at it. And I would actually expand beyond just the ACEs to include issues like poverty and racism and impacts of those. They didn't get the short list on the ACEs, but I think people are taking a second look at ACEs and expanding that to think about other ways that environmental factors are playing or having a negative impact in a child and family's functioning. And I even think that it wouldn't hurt sometimes to have your staff take a look at their own ACEs, not necessarily sharing those publicly, but many of our staff, particularly those that are doing frontline work, in-home work, carry a lot of adverse childhood experiences themselves. And again, there's been criticism about, ACEs is kind of fatalistic almost. And, what do we do with that information in a way that can affect and inform change in an individual's life? But I think if we think about the ways in which the ACEs study has shown that it then drives maladaptive coping strategies, I think it can open up a conversation. And so while it's not a specific screening or assessment tool per se, I think it can get at some of those same social determinants of health in a productive way if it's used appropriately.
Thank you. You're getting some thanks in the chat box. And Audrey is also noting that Dr. Wade has added 5 additional questions to the original ACEs questionnaire that engage social determinants of health. Julia Reed is also saying she likes the use of PACEs as an add-on to doing the ACEs. Cassie, I'm going to turn back to you. You mentioned your complexity tool. That was very interesting. And it spoke to service plans and movement towards service plans. But could you talk a little bit more about how do you train your staff overall to use screeners or assessment tools to incorporate into service plans, not just the complexity tool?
Sure. That really is as we are onboarding people or as they're coming into our program, we are usually, that's just part of our onboarding process. So they're meeting with somebody who's already doing it, who's doing those comp evals, and they are going through them, and we're really digging into them and explaining what they are, how to do them, how we use them, and how we're going to use those for that client-centered care. So it's really kind of a train from somebody who's using it, as a tool to help the families out, and then training the new people in how to do that.
Excellent, thank you. I'm going to move over to our question and answer box. It looks like we have that turned on today. There's a question. Are these screenings that are targeted for young adults 17 to 26 and a family assessment geared towards understanding how the family will be able to handle services? Opening that up for the group. How do we look at the family's needs, especially when when we're serving a young adult, I think is the question.
I'm gonna have Cassie take it from here, but I think our friends at Child Welfare and also Behavioral Health Division, we are looking a lot at CANS. That assessment tool has like a separate component on family needs in context to the child or youth's mental health. So I would encourage people to, it's not a screening, it's a full-fledged assessment. But CANS is one tool that has come across widely being used right now to assess the family needs. And then our child and maternal screening for maternal depression during, as I mentioned in our child and teen checkup, that also checks, but it's primarily for maternal health. So it does not talk about like overall family's needs, but CANS is something I would highly encourage people to look at it. Cassie, do you want to add anything on the?
Yeah, I was also confused by the term service member.
I have a clarification, and thank you, Jessica, for jumping back into the chat. The question is for how will the family be able to handle service members, meaning they are in the armed services? Do we have assessments that go to speak to that? And we're stunning the panel here, Jessica.
I'm not aware of any, otherwise I would certainly share.
Yeah, I'm not either. Neerja?
Again, like kind of two things come to mind. One is looking at the cultural formulation interview document at DSM. That really helps to understand the family's perspective regarding the specific concerns the child is bringing in, and if the services are referred, what would be the family's reaction or what would be the family's response. So cultural formulation interview, that is helpful. And then again, I would ask people to look at CANS because I have found it very helpful. It has a separate section on parents' perception regarding their child being in services. So it's not directly answering, but just something to look at.
That's helpful.
When I would also just wonder about, trauma and loss associated with service members, not necessarily, that they've died in military service, but just the loss in terms of parents on active duty assignments, coming in and out of the home. We have many women in the military who have children, so it's not just fathers, but also mothers. And so thinking from that loss perspective, and many of our military service members have also had difficult childhoods. And so I think also the ACEs with the add-on components that some people in the chat have recommended could also help to flesh out those needs for that family.
Thank you. We're going to go to Raquel's question. Any suggestions on suicide assessments for ages 5 to 10? She says that they use the SAFE-T, which is based on Columbia, but making the words age appropriate for understanding can be a struggle. Do any of you have suggestions for that?
I would say we're wrestling with the same thing. The age appropriateness and how to ask it has been a struggle. That's part of our complexity scale process here. So any suggestions will be welcome here too.
I think just like we don't have evidence-based practices to meet every condition or have been tested in every population, we also don't have screening and assessment tools for every population or every condition. And so I think the creativity that you're showing in trying to take an established normed assessment instrument or screener and then coming up with developmental language, you may lose some of the fidelity of the screening and assessment instrument, but it's probably going to be the best that you can do because while we do need a prepubertal suicide screening, sadly, because we do know that that is a cohort who's actually had some increase in suicidal activity over the last decade or more. In the absence of having something that you could take off the shelf, I think that is when you have to think creatively about adapting it. But then also, I think you would have a responsibility to make sure that you're seeing whether or not it seems to have relevance and applicability, i.e., are you finding when you're starting to implement the adapted version that you've developed, does it seem to be working? Does it seem to be corresponding with what appears upon treatment intervention is indeed the diagnosis that you had positively screened for? So it's do your best in the absence of the perfect. So I applaud, what you're doing in terms of adapting the Columbia.
Great, thank you. Cassie, I have a question for you. When you have a client in your child and adolescent group and they transition to adult services, do you transition that assessment information with them, or does that person have to go through reassessments? How does that work on the ground?
We usually just transition that with them, as they travel into the next. And then, the assessments change a little bit as they, age into the next bracket up. But it travels with them. And there is a lot of coordination between the providers of who is kind of taking over in what ways to make sure it's pretty seamless for the client.
Great, thank you. Let's talk about training on your screeners. And is there a refresher course that you require to ensure that the person using the screening and assessment tools are using them to fidelity?
Yes, we have a review every year, regardless of how many years you've been doing the screeners, that everybody goes through on a yearly basis to make sure that they're up to what the standards are.
Great, thank you. So there was some more back and forth, and you were getting thanks, all of you in the chat, about tools, follow-up responses on tools for members that are 17 to 27 or 15 to 25 or transition age youth range. For those of us that are participating by the recording, listening to the recording, Cassie, do you mind sharing what you shared in the chat box about that follow-up?
Yes, so we use the DLA 20 in place of the SDQ as our youth get older. And then most of the screeners, including the PTSD, the CAGE aid, the PHQ, that changes to the PHQ 9, so it's not too much of a change. And then the Columbia Suicide Screener are really consistent from 11 all the way to end of life. So it's only a couple of screeners that really change for anybody as they grow into a different program.
Great, thank you. Well, I have to say, the three of you are getting a lot of kudos in the chat, some spot on. Clement, obviously, we had the right group of panelists for today's presentation.
I was a little surprised nobody brought up the issue of workforce shortages.
Well, go for it, Dr. Bellonci. We have 2 minutes left.
Well, I always worry that if you don't, the whole purpose of screening and even assessment is to identify a need and get the individual into service as quickly and efficiently as possible. So assessment helps to get you to the specific intervention that's going to be most effective for you. Screening identifies the need. But if we don't have a workforce that's trained in these evidence-based approaches to then pick up the baton once that need is identified, I always worry it's a disincentive to do the screening, because then you're even in a worse situation. You've identified a need, but you don't have a resource to meet that need. Now, I know that that's from a policy perspective why SAMHSA has increased the funding for CCBHCs so significantly. It's a direct response to an identified need. But I'm wondering how that's working in practice, and whether or not any of the folks that are listening in and participating in today's webinar have similarly been concerned or seen examples where practitioners are actually reluctant to screen because they don't have a place to then refer once they identify the need.
Dr. Bellonci, you have queued us up perfectly for our final webinar in this series, which is largely on workforce. So that will be in October. Look at that. We didn't even plan that.
We
right?
did not even plan that.
So those of you who have participated today, if you have suggestions and would like to be featured, or some of your techniques or strategies highlighted in our closing webinar in this series in October, please send them our way. Thank you very much for joining, and let's cue the video.
Thank you for joining this month's Child and Family Focused Certified Community Behavioral Health Clinics Learning Community, hosted by the CCBHC Expansion Grantee National Training and Technical Assistance Center. Please take a few moments to complete the evaluation for this workshop using the following link being posted in the chat. We will be providing a certificate of attendance for completion of each workshop being offered throughout the entire series. So make sure you're registered with the same name logged into each webinar so that we can confirm your attendance and the total time you were part of this workshop. Please allow up to 10 business days for your certificate of attendance to become available in Ideas at the Institute. Any presentations, resources, and webinar recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all the upcoming and previously recorded webinars. With our goal to support increased access to and improve quality of CCBHCs in meeting the needs of youth and families, we hope you join us again for Mobile Response and Stabilization Services, an essential support for youth and families. You can access the Zoom link for each workshop and download a calendar appointment for that workshop by logging into Ideas at the Institute. Access the CCBHC Learning Community curriculum and click the View button for the upcoming webinar. I hope that today's session has provided you with greater understanding of the value of children's services and the role of child-serving systems as you continue to identify and implement approaches to meet the unique needs of children, youth, and young adults with behavioral health needs and their families. Thank you for joining us today, and we look forward to seeing you at the next workshop.